right?
Hi, everybody. Can you hear me?
Very well, thank you.
Yeah, yes,
Okay.
yes.
Okay, we should start. Okay. Hi, my dear co-chair, Dr. Embari, and distinguished speakers from 5 countries. Good morning and good afternoon. Welcome to this APSC Cloud Forum of Cardiovascular Disease Series. The program today is entitled Fighting Obesity to Improve Cardiovascular Outcome, Novel Weight Loss Therapies on the Horizon. As we know, weight loss strategy in overweight and obesity has been uncertain for decades in regards of cardiovascular outcomes until the emergence of convincing benefit of bariatric surgeries, also named sleep gastrectomy, Roux-en-Y gastric bypass, in observational studies, recognized as a disease, not a lifestyle choice. Obesity and obesity-related cardiovascular comorbidity, mainly heart failure with preserved ejection fraction, are now successfully managed by intensive lifestyle intervention, including exercise and the dietary approach. Novel GLP-1 receptor agonist, especially semaglutide, as well as novel GLP-1 and the GIP dual receptor agonist, tirzapatide, in addition to bariatric surgery, all with evidence of cardiovascular outcome improvement. In the era of obesity pandemic, we, as cardiologists, should be ready and well-equipped to fight against overweight, obesity, and obesity-related cardiovascular complications, not only heart failure. I am Dr. Roux-en-Y from McCain Memorial Hospital in Taipei, Taiwan. It's my great honor and pleasure to be the chair of this program. My co-chair is Dr. Eddie Median Embari from Indonesia. Dr. Embari, would you like to say some word?
Thank you very much, Professor Liang. And then thank you very much, Professor Lin. Nice to meet you all in this morning. And then hopefully that we can have a good discussion in this morning. Thank you very much.
Thank you. So now I need to go to disclaimer. The content of this webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. And some housekeeping points. The live streaming content of this webinar will be made available via APSC Cloud, APSC Facebook, and the YouTube page. Now, let's get started. The first speaker is Dr. Tahir Shah from Pakistan. Dr. Shah is now professor and the head of cardiology department, Kuwait Teaching Hospital, located in Peshawar Medical College, Pakistan. His topic today is obesity is a disease, not a lifestyle choice. Relevance to hypertension, diabetes, ASCA, heart failure, atrial fibrillation, and obstructive sleep apnea. Dr. Xia, please.
Slides are visible. Hello.
Yes, Dr. Shah. I think that you should slide slow.
Yeah.
Okay, that's good. Yeah.
You can see. So I'm Professor Dr. Syed Tash. I'm working at Quay Teaching Hospital. Thank you very much for inviting me for this very important topic and discussion of obesity and its relevancies and then new modalities of treatment. And at the same time, I'm thankful to Professor Mahmoodul Hassan, who is the president of Pakistan Cardiac Society, who was given this opportunity to talk about obesity. So my topic is obesity, a disease, not a lifestyle choice. And it will be in the relevance of hypertension, diabetes, atherosclerotic vascular disease, heart failure, atrial fibrillation, and obstructive sleep apnea. I will cover all this in this presentation. So I have no disclosure for this presentation. And the outline for my presentation will be definition of obesity, classification, epidemiology a little bit, and then types of obesity, etiology, then association with hypertension, diabetes, atherosclerotic disease, heart failure, atrial fibrillation, and obstructive sleep apnea. And then comprehensive management strategy, which will be covered in detail in the following presentation after me. And then question and answer session. So obesity is a medical condition in which excess body fat accumulates to the extent that it may have a negative effect on the health, leading to reduced life expectancy and or increased health problems. So obesity is now a disease. It's not a lifestyle choice. It's a disease because it's recognized by AHA and EAC as obesity is a disease. When we come to the classification of obesity, if it is on the basis of BMI and it is more than 30 or more, we call it obesity. Now there are three classes of obesity. One is class 1, one is class 2, and the one is class 3. These are all on BMI basis. And class 1 is 30 and less than 35. If it is 35 and less than 40, that's class 2. And if it is more than 40, then it becomes class 3. So severe obesity, very severe. If it is the obesity is very severe, there is a very high risk of comorbidities with it. So it's important to understand the basic concept of obesity. When it comes to Asia Pacific, then the overweight criteria comes down and it's 23 to 24.9 is overweight. And if it is more than or equal to 25 kilogram per meter square, then it's labeled as obese. Now, a bit epidemiology, obesity has become a global pandemic. And in 2022, 1 in 8 people in the world were living with obesity. Worldwide, adult obesity has more than doubled since 1990, and adolescent obesity has quadrupled. And that's a very alarming sign that adolescent people, the adult people, more are getting obesity. And that's something we should think about and work before it hurts us very badly. In 2022, 2.5 million adults, which constitute 43%, were overweight. Of this, 890, which constitute 16%, were living with obesity. That's 2022, and in 2024, it will be much more sky high. 2.5 billion adults were overweight in 2022, and 890, which 16%, were living with obesity. 37 million children under the age of 5 were overweight, and 390 million children and adolescents aged 5 to 9 were overweight, including 160 who were living with obesity. So if you take less than 5-year age, still we have a lot with obesity, with overweight 37 million. And if it is 5 to 19, the overweight goes up as well as the obesity. And this is a source, WHO 2023. There are different types of obesity. One is because of the physical inactivity, and the stronger body parts accumulate fat and become unhealthy. Then the food obesity, unhealthy food and excessive sugar intake, and then fat accumulation around the middle part of the body. Then anxiety-related obesity we have, and then we have venous obesity, which is related to genetic factors affecting venous circulation, and which is common during pregnancy, and exercise can be beneficial in this type of presentation. Then we have gluten obesity, which is triggered by gluten sensitivity, and there are hormonal changes, this particularly during puberty or menopause, and it's more common in women. Then we have a very common atherogenic obesity, and that's very important to know about it. The fats accumulate in the stomach area, and which can affect the other organs and cause breathing issues. Avoiding alcohol is essential for managing this type of obesity. Now, the etiological, if you look at the causes of obesity, so many factors, it's a multifactorial phenomena. It's not single, just one risk factor or one etiological cause which is causing obesity. So behavioral, lifestyle, and other factors influence obesity. Unhealthy diet, too much carbohydrates, and unhealthy, nutritionless food intake. Sedentary lifestyle is an important factor. We have less physical activity, more weight gain, and this sedentary is strongly linked to obesity in both men and women. And then medication, some type of medication, which is antidepressant, anticonvulsant, diabetes medicine, they can cause at the same time obesity as well, looking after diabetes, but it can cause obesity. And then hormones like oral contraceptive and corticosteroids. Diseases like Cushing disease, polycystic ovarian syndromes, thyroid and endocrine disorders can lead to obesity. And then mental health problems such as depression, eating disorder can lead to overeating and weight gain. And then genetic itself, obesity can be hereditary. If parents are obese, the risk is higher. Genetic influence is hormone involved in fat storage, such as leptin deficiency, which can cause obesity. So these are behavioral, lifestyle, and hereditary changes which can lead to obesity. A concept is very important, and that is adiposopathy, which is also called sick fat disease. That's an important concept. And if we understand adiposopathy, which is a combination of immunopathy, endocrinopathy, and free fatty acid, and ultimately leading to insulin resistance in case of diabetes, and so many inflammatory markers and hormones are released. And this abnormal fat can lead to a lot of consequences in the type of diseases like type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, cancer, and so on. So health consequences of obesity are a large number of health consequences, and a lot of things, a lot of the systems are involved in the human being because of the obesity. But here I will my focus will be on hypertension, diabetes, atherosclerotic cardiovascular disease, heart failure, atrial fibrillation, and obstructive sleep apnea. So I will be focusing on this a bit. The management step will be covered later on. I will be just giving its importance and pathophysiological aspects. Now, coming to obesity and hypertension, obesity is a major risk factor for hypertension. And that's a very common phenomena that obesity can lead to hypertension, and it's a very important risk factor as well. So increased visceral adiposity accounts for 65 to 75% of the risk of primary hypertension. There are three main mechanisms. One is sympathetic nervous system activation. So the heart rate goes up, cardiac output is increased, and renal sodium reabsorption is increased, leading to hypertension. Elevated muscle and renal CNS activity contributes to high blood pressure. Then we have RAS overactivation, increased level of renin, angiotensin 2, and aldosterone lead to sodium retention and vasoconstriction. And then we have a very important phenomena of insulin resistance, and that promotes sodium retention, reduces vasodilate response, increasing vasoconstriction. And this is summarized in this figure. So sympathetic nervous system activation activation of renin-angiotensin-aldosterone system, and then the very, very important is insulin resistance leading to hypertension. Adipokines, leptin resistance, and adipose tissue dysfunction are the two common phenomena that is leading to inflammation and CNS activation leading to hypertension. Central obesity, when we are talking of visceral or central obesity, it is a strong predictor of hypertension than overall obesity. And waist circumference and waist to hip ratio are better predictors of cardiometabolic risk. Now, if waist circumference is more than 102 centimeter, which is 40 inches, or more than 88, which is around about 35 inches in women, and that's a link to high prevalence of hypertension. From Framingham study, 78% of new hypertension cases in men and 65% in women are due to obesity. That's a very big number, and that's because of the obesity. From Narcissism study, we have 5-fold higher risk of developing hypertension compared to women with a BMI less than 23. So lower the BMI, the lower the risk of hypertension, and that's what's seen in Nurses' Health study. Treatment strategy, I will be just touching upon weight loss, and if you have 4.5 kg lowers the hypertension risk by 65%. So just 4.5 kg reduction, and it's 65% lowers the hypertension risk. Very important to lose weight. Then lifestyle changes, important. And then the pharmacological treatment, we have the group of medicine, ACE inhibitors, ARBs, and then we have calcium channel blocker diuretic second line, and then we have third line beta blocker used selectively due to potential weight gain. Metabolic surgery, when it comes to bariatric surgery, it's getting a very important role now in management of obesity. So when we are talking about management overall, bariatric surgery is a very important component of dealing with any type of obesity, particularly when the BMI is more than 40 and it is not controllable and leading to very high risk and comorbidities in patients. So bariatric surgery, important, different patterns, different techniques. And what it does, it reduces hypertension in over 50 to 60% of patients. Almost in 2 patients, 1 patient get reduction of hypertension. Gateway trial, 56% remission of hypertension after bariatric surgery, BP reduction observed within 1 week post-surgery, indicating neurohormonal effects. Now, coming to another important association after hypertension, the another important association is of obesity and diabetes. Diabetes is a chronic disorder, and it is affecting carbohydrate, protein, and fat metabolism. Obesity is a significant risk factor for both type 1 and type 2 diabetes, and rising global obesity rates contribute to increased prevalence of diabetes. So obesity, when there is obesity, there is a very high risk to have a diabetes. So we have studied the epidemiology in 2.5 billion people are living overweight, 16% are with obesity. In the Diamond study, 2.8% annual increase in type 1 diabetes among children. In the US, 2/3 of adults are overweight or obese, and projected increase in type 2 cases to 360 million by 2030. A very alarming figure as well. Again, diabetes is becoming another important risk factor, and obesity is contributing a lot to it. Unhealthy diet and physical inactivities, poor compliance with medication. So many things comes in when it is managing the obesity and diabetes. Pathophysiology of type 1 is just simpler in the form it is autoimmune mediated, and then there is a concept of accelerated hypothesis, which is when there is obesity, it increases the risk of type 1. It put the patient, the children at risk of earlier start of diabetes because of the insulin resistance, and then rising obesity rates correlate with increased type 1 diabetes cases. When it comes to pathophysiology of type 2 diabetes, the two basic concepts are insulin resistance and beta cell dysfunctions. So insulin resistance is caused by this non-esterified fatty acid or free fatty acid and hormones and cytokines from the adipose tissue, and this lead to reduced glucose uptake in the muscle and increase hepatic glucose production. By beta cell, these beta cell of the pancreas, when they are exposed to fatty acids, lipids, fatty acids, as well as to hyperglycemia, increased sugar, then it can lead to glucotoxicity, and it can lead to lesser function of the beta cell, lesser insulin secretion, and that can lead to further increase in glucose. Obesity exacerbates beta cell dysfunction. So this non-esterified fatty acid, what it does, decrease insulin sensitivity, impaired glucose stimulated insulin secretion, and development of a glucolipotoxicity, which is hyperglycemia and increased fatty acids, and its composition causes toxic effect on multi-organs, resulting in glucolipotoxicity. Impact of body fat distribution. Central obesity is more harmful than peripheral fat in causing insulin resistance. Waist circumference and waist to hip ratio are better predictor of metabolic risk than BMI alone. Abdominal fat is more resistant to anti-lipotic effects of insulin, promoting insulin resistance. So preventive strategy and management, this will be discussed in detail. Lifestyle modification. Then we have pharmacological approaches. We have GLP-1 agonists, SGLT2 inhibitors, and then we have bariatric surgery. So these are how to be approached. Now, coming to third parameter we will discuss after hypertension, diabetes, we have atherosclerotic cardiovascular disease association. Before 1990, 40 years ago, it was obesity prevalence was less than 10% in high-income countries. But now the obesity rates have increased to 25 to 40%. And previously, cardiovascular risk factors, if you look at the historical focus, like smoking, high blood pressure, and high cholesterol dominated. But now this is current challenge. And for cardiologists, we are now facing increased obesity-related cardiovascular condition, and this challenge, we should take it and go ahead with it, and combating these obesity comorbidities and its side effects. So looking at this 1990 and 1980, there's a low prevalence of obesity, high prevalence of hypertension, LDL cholesterol, and smoking. This is high risk, leading to MI, stroke, and CV morbidity. Heart failure survival was short. Focus on smoking cessation, statin use, BP treatment lead to reduced CV risk, and later interest in obesity by cardiologists at that time, because it's just less than 10%. Now, present day, you look at it, obesity is getting more, smoking and these risk factors are getting controlled by different methods. Now, 40% adults are living. So the CV death goes down, and there is a heart failure increased survival because of the good armamentarium of treatment available for the heart failure patients. So more obese-related comorbidities due to exaggerated or high aggregated exposure to obesity, plus higher heart failure and stroke risk at younger ages. Now, the net increased impact of the obesity on atherosclerotic risk factor is increased evidence for causality of obesity for heart failure with preserved ejection fraction, atrial fibrillation, hypertension, and systemic inflammation. What is happening? We have evidence that weight loss medication decrease atherosclerotic cardiovascular disease, heart failure risk, improve preserved ejection fraction symptoms. And this is because of this long list of medications, GLP-1, GIP, and that's all. And again, this surgical intervention. But now the problem is hurdles for clinical implementation of weight loss therapy, high cost. Cost is very high for that therapies, number one. Limited third-party payer coverage, limited availability of medication, and need for education of cardiologists to address clinical inertia. The last step is again very important, to hone this obesity as a disease and to treat it accordingly. Key drivers: availability of calorie-rich and nutrient-poor foods, and increased sedentary lifestyle. This is rising obesity rates and cardiovascular impact. Changing demographics. Obesity rates are rising among younger population with longer duration of obesity-related risks. Cardiovascular outcomes. More patients with obesity are surviving longer due to better treatment, leading to increased multi-morbidities. Obesity role in cardiovascular disease is causal link is, and then new evidences are this heart failure and atrial fibrillation, significant mediator for cardiovascular disease and cardiovascular death, obesity. And then it is associated with the risk factors such as blood pressure, diabetes, and dyslipidemia. Now, what happened in the new evidence is that incretin-based therapies, just like GLP-1 agonist, show benefit in reducing cardiovascular risk in patients with obesity. So this is a trial. It will be discussed in detail. So weight benefits are multifocal, reduce sympathetic nervous system and RAS activity, reduce inflammation, cardiac remodeling, and improve hemodynamics. Obesity and heart failure is both a risk factor and a direct cause of heart failure, associated with adverse hemodynamic changes leading to cardiac remodeling and ventricular dysfunction, can cause heart failure even without other comorbidities like hypertension and coronary artery disease. Up to 86% of patients with heart failure with preserved ejection are obese. Class 3 obesity significantly increases heart failure risk even in the absence of hypertension and CAD. Pathophysiology, hemodynamic changes, and cardiac remodeling. Hemodynamic changes are increased cardiac output, stroke volume due to higher blood volume, elevated left ventricular filling pressure and right heart pressure leads cardiac remodeling leads to left ventricular hypertrophy and potential progression to heart failure. So concentric or eccentric LV is based on obesity type, central versus obesity versus peripheral. Insulin resistance, neurohormonal and metabolic phenomenon, leptin resistance, hyperleptinemia, hyperinsulinemia, and the ROS system overactivation, and then lipotoxicity, all are the risks, are all the pathophysiological constituents of obesity. There's the obesity paradox. Overweight and mildly obese heart failure patients have a better survival rate than normal or underweight individuals. Possible reasons include greater metabolic reserve and less frailty. Underweight and heart failure patients have the worst prognosis. So hemodynamic improvement occurred because of the weight loss in cardiovascular health and cardiac morphology, reduction in LV mass, wall thickness and chamber size, and improvement in LV diastolic dysfunction. So strategies will be lifestyle modification, pharmacotherapy, and surgical intervention. This will be discussed in the treatment of GLP-1 agonist. Atrial fibrillation, most common cardiac arrhythmia affecting 60 million people worldwide, increase the risk of stroke, heart failure, dementia, and hospitalization. If incidence predicts the increase, if incidence predicted to increase by over 60% by 2050. And it's the strongest predictor of AF after hypertension. Obesity increases AFib risk 50% from young. A 5-unit increase in BMI leads to 30. This is very important again. If 5-unit increase in BMI, that can be lead to 30% increase in AFib incidence. And obesity-related comorbidities other than this are present AFib, and that can contribute to atrial fibrillation as well. So pathophysiology is structural and electrical remodeling of the heart. Then we have epicardial adipose tissue plays a key role. And then we have contributing factors like adiposity, inflammation, fibrosis, oxidative stress, and autonomic dysfunction. This all contributes to this atrial fibrillation. 8, located between myocardium and vessel epicardium. This is epicardial adipose tissue, a paracrine signal effects, and then increased atrial volume linked to LA enlargement, fibrosis, and atrial fibrillation. And then this epicardial adipose tissue secretes pro-inflammatory, pro-fibrotic, and pro-arrhythmic substances. And once it's there, it elevates the volume, the atrial volume increases, and it increases atrial fibrillation vulnerability. This is the mechanism. We have hemodynamic changes, inflammation, and then fibrosis, oxidative stress, autonomic dysfunction, and it leads to ectopic activity, re-entry, and atrial fibrillation.
Dr. Xia, please.
So short and effective
reflective.
Just two slides. So further, I'm going to treatment option, obesity, altered pharmacokinetics and efficacy of anti-arrhythmic drugs, high recurrence rate of atrial fibrillation, post-ablation, altered response to beta blocker, anticoagulation, and therapy. So we have reduced AFib burden and recurrent post-ablation. Bariatric surgery shows improved AFib outcome by reducing this eat, volume, and fibrosis. Lifestyle modification are significant. So obesity paradox, will skip this slide and come to treatment, which will be again discussed in detail, but direct oral anticoagulation or warfarin is a drug of choice. And then class 3 drugs are superior to class 1. And then ablation is important component of the management. Sleep apnea affects multiple systems, especially cardiovascular health, key associated condition, hypertension, diabetes, systemic inflammation, and obesity significantly increases the risk of obstructive sleep apnea. Prevalence is 25% in adults, but it is obesity. If it is obesity, then it's 45%. Higher prevalence in men, postmenopausal women, and with age. Obesity epidemic contributes to rising obstructive sleep apnea rates. Mechanism is fat deposition in the upper airway tissues, leading to airway narrowing, visceral fat increase, chest wall, reducing lung capacity, systemic inflammation, and metabolic dysregulation worsen obstructive sleep apnea. So management is CPAP, and then weight loss, surgery, and multiple approach needed for long-term management. Role of weight loss is there because weight loss improves obstructive sleep apnea severity, reduces blood pressure and inflammation. Bariatric surgery effective in reducing apnea, hypnea index AHI, and sustained weight reduction critical for long-term benefits. This comprehensive management strategy, I will skip this slide and come to conclusion. Obesity is now a major driver of cardiovascular disease. Cardiologists must prioritize obesity management to prevent further increases in multimorbidity. The time is now to address obesity as a public health crisis in cardiology. And with this, thanks. Any question and answer, we'll be happy to answer. Thank you very much.
Thank you, Dr. Shah. Very detailed and good introduction and explanation. I think we can know the epidemiology as well as all the cause of obesity now affecting all the world. Any question from our audience or our co-chair?
Okay, thank you very much, Professor. Professor Shah, I would like to ask you about the obesity paradox, especially in patients with heart failure. Is that all kind of obesity or just overweight and obesity type 1? It is give a benefit effect as a obesity paradox in patients, or even stage 2 and stage 3 in patients with obesity. What kind of the overweight or obesity type 1 is give an impact, or but type 2 and type 3 is not a give big impact to the heart failure patient, in the prognosis.
Dr. Shah?
Yeah. So obesity of type 2 and type 3 will have the adversity as well. But this is shown that paradox exists. But again, this needs further workup and further detailed studies, randomization. We will be then in position to know the paradox effects. But it is for overweight and class 1 obesity, not for class 2 and class 3. Mostly class 3 patients with heart failure have adversities, and it's related to the weight and other inflammatory markers involved in obesity. At the same time, insulin resistance, which is a big culprit for all this stuff, inflammation and insulin resistance. These are the two things that make it more worse in case of any condition. And for heart failure, so that's a paradox exists, but still it is a questionable thing for class 3 and 2.
Thank you. I think because of the time constraint, we need to go to the next session. Thank you, Dr. Shah, for the very nice and very detailed introduction explanation. Thank you.
So welcome. Thank you.
Thank you. So now we move to the next speaker. Our next speaker actually is our co-chair, Dr. Ambari. Dr. Ambari is now president-elect of Indonesia Heart Association, as well as National Board of Exercise is Medicine Indonesia, Vice Secretary General of Non-Communicable Disease Alliance Indonesia, Chief Medical Service Development in National Cardiovascular Center, Aparan, Kita, Jakarta. as well as Indonesia Heart Foundation. Today, he will give us a talk entitled Lifestyle Intervention, Exercise and Dietary as the Foundation of Weight Loss Therapy in Obesity and Overweight with or without comorbidities, seen through a heart failure action. Dr. Amari, please.
Thank you very much, Professor Ye. I think that's my slide is clear.
Yes, clear.
Okay, thank you very much. First of all, I would like to say thank you very much for the FPST who invited me as speaker in this afternoon and co-chair, especially for Professor Lin. And then thank you for the introduction, Professor Wei. This morning, I would like I will talk about the lifestyle intervention, exercise and diet, foundation of weight loss therapy and obesity and overweight insight from the AHEAD and HF action studies. Okay. Okay. First of all, Professor Shah already explained about the obesity and overweight. We know that obesity is commonly characterized by excess body weight for head, and then due to that we use a BMI. However, this straightforward definition obscure and complicated etiology that is principally linked to excess adiposity or body fatness, which can be expressed metabolically in additional to physical dimension. And then it is stated that globally, we define overweight if the BMI more than 25 and then obese more than 30. And then, however, in Asian population, we have a different classification system. And then from the Asia Pacific region, from the WHO, we know that we define the obesity if the BMI is more than equal 25. This is the global prevalence. I would like to say that obesity, the prevalence of obesity and overweight in high and upper middle income Asia Pacific country is twice as high as in lower middle and low income Asia Pacific country. And I think it is the prevalence about 39% in men and 40% in women. And then the overweight is 11% in men and 15% in women. And then what is the link between obesity and multiple comorbidities? We know that more than 20 illnesses, including type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, and other are linked to the obesity. And then obesity has a profound effect on patients' psychological well-being, in addition to their physical health, and it's linked to low self-esteem, higher rate of depressions, and lower quality of life. And then what is the importance of lifestyle intervention in weight management? We know there is a guideline, which is a recommendation for adults with overweight and obesity. It is stated that these adults who are overweight or obese are more likely to suffer from atrial fibrillation that Professor Shah stated before, heart failures, and ASCVD, atherosclerotic cardiovascular disease, than those who are of a normal weight. And then current clinical guidelines strongly recommended weight loss maintenance program that are delivery in person or over the phone or involve regular contact, at least that monthly with a trained interventionist to help participants maintain a reduced calorie diet, engage in high level of physical activity, about 20 to 100 and 300 minutes per week, and regularly monitor their body weight at least weekly. And then how about the study about the obesity, about the physical activity and diet? I think we can learn from the look ahead on weight loss in individual type 2 diabetes and obesity or overweight. This is a action for health in diabetes. This is a study actually in patients with diabetes and obese. This look ahead this life intervention trial. And then the objective of this trial is to investigate it whether cardiovascular morbidity and mortality may be reduced by an intensive lifestyle intervention for weight loss. And then the method, there is more than 5,000 overweight and obese patients with type 2 diabetes, and then they compare between the intensive lifestyle intervention or lower calorie intake and then increased physical activity, and then they compare with diabetes support and education just as a control. And then the goal of intensive lifestyle intervention was to produce a 7% weight loss through calories restriction and increase physical activity, and to produce more significant improvement in cardiovascular fitness than in diabetes support education only, or DSA. And then even though with a primary outcome result, intensive lifestyle intervention not reduce the cardiovascular death mortality and morbidity in individuals with overweight and obesity and type 2 diabetes. But I think while the primary outcome show no reduction in cardiovascular disease, morbidity, mortality, the intensive lifestyle intervention goal was achieved. And this study offers valuable insight through extensive additional analysis. This is, if you see the result, the effect of intensive lifestyle intervention on its direct target, we know that intensive lifestyle intervention can reduce the weight and increase the cardiovascular fitness. Over the course of the trial, the intervention group lost more weight than the control group, about 8.6% versus 0.7 after 1 year, and then 6% to 3.5% at the study ending. I mean that until 2 years post-intervention. Intensive lifestyle intervention participants show more significant fitness improve at year 1, I mean in the first years. And then the 4th years, with the large difference in the first years. I mean that it will be increase the cardiovascular fitness and reduce the weight. The goal of intensive lifestyle intervention was to produce 7 weight loss through calories restriction and increase physical activity, and to produce more significant improvement in cardiovascular fitness than in DSA. Okay. What is the effect? I'm sorry. Okay. And then compare with those with low physical activity volume and weight loss, maintaining the physical activity volume and weight loss was associated with a 61% lower risk of the primary endpoint. Along with more significant initial improvement in fitness and all cardiovascular risk variable, of course, that with the exception of low density lipoprotein cholesterol level, the intensive lifestyle intervention also resulted in high reduction in in HbA1c. Participants with evidence of any remission during follow-up had 33% low rate of CKD, 40% lower rate of composite cardiovascular disease, and then from recent post-hoc analysis in look ahead study. And then what is the lesson learned from look ahead study? First, about the lifestyle intervention. Intensive lifestyle intervention combine diet, exercise, and behavioral strategy effectively result in successful weight loss. And then secondly, about the cardiometabolic benefit, it will be improved cardiovascular risk, including better glycemic control, increased cardiovascular fitness, and reduced blood pressure, and even in the absence of significant reduction in major cardiovascular disease event. Diabetes readmission is a measurable goal, and then behavioral support, regular counseling, and self-monitoring help participants sustain weight loss and lifestyle changes. And then the 4th is long-term commitment. Of course, that sustained adherence for lifestyle changes was essential. for the maintaining benefit. The other study that's very interesting, we learned from the HF action or physical activity for individuals with heart failure patients. And then the HF action, this is a lifestyle intervention with a patient with heart failure. The objective is to evaluate the safety and effectiveness of exercise training for heart failure patients. And then the primary objective was to assess the impact of exercise on all-cause mortality or hospitalization. And then it involved about 2,300 medical stable outpatients with heart failures and reduced intervention. And then the intervention, of course, this is the RCT, they interfere with the usual care only or usual care plus aerobic exercise training. And then after adjusting for highly prognostic baseline characteristic, exercise training was found to reduce the incidence of all-cause mortality and all-cause hospitalization by 11%. Both cardiovascular mortality or heart failure hospitalization and all-cause mortality or hospitalization were also shown to be relatively significantly reduced by exercise training, even after controlling for highly predictive indicator of the primary and outcome. The changes in cardiopulmonary exercise testing parameter and distance in 6-minute walking test consistent with the finding of a modest benefit in reducing the clinical event. And then the result also show improved cardiovascular fitness at 12 months, despite no significant difference in 6-minute walking test. The study reports some challenges related to issue of adherence and site variation. And then this issue show us that the need for the better support, accessibility, and the standard protocol to improve the exercise intervention. And then the recent analysis from the HF action is that the aerobic exercise training was associated with a significantly lower risk of the primary composite endpoint and all-cause hospitalization among frail but not frail participants, and then no significant reduction in risk of all-cause mortality with aerobic exercise training among frail and non-frail participants. But I think the point is that aerobic exercise training did not increase the risk of the adverse events such as worsening heart failure or hospitalization in both frail or non-frail participants. It means that the aerobic exercise training is relatively safe to patients with heart failure. And then frailty status may influence the extent of this benefit, emphasizing the importance of personalized exercise intervention. And then the role of exercise in weight loss therapy, I mean that the physical activity, exercise training program, for example, it is can reduce the weight, and then the weight maintenance can optimally reduce cardiovascular risk in overweight and obese patients based on the physical activity level or exercise type. According to the STRIVE study, the prevalence of clinical significant weight loss 7.6% of low amount or moderate intensity training. I mean that, and then 9.3% of low amount high intensity training and 40.3% for high amount and high intensity training. I mean, it will be reduce the blood weight more than 5%. And then if you combine between calorie restriction with the aerobic exercise training, it will be reduce the weight to 5 to 50%. And then it's very, very good. I mean, the combination. And then physical activity, exercise training, and weight loss can improve the lipid profile and insulin sensitivity compared to exercising without weight loss. And then how about the dietary intervention in weight management? Dietary intervention can contribute to weight loss, which change total fat and lower the rate of major cardiovascular event. The recommendation include, there is 5 recommendations. First, about the energy restricted diets. greater calorie restriction. Of course, that it will result a negative energy deficit and is associated with a faster rate of weight reduction. When combined with lifestyle modification, low energy diet with 800 or 1800 kilocalorie per day energy intake target can reduce 5 to 8 kilos weight loss in 6 months. Secondly, about the portion control diet, using meal replacement, simplified food preparation and planning, lower cognitive demand and decision making, and minimize sign of overeating. And the other thing about the intermittent energy restriction, intermittent fasting, I think that's very good. With the fast day, more than 60% energy restriction in 2 or 3 days a week. And then time restricted feeding, eating for 6 hours, and then the fasting for remain 16 hours of the day. The other recommendation is macronutrient focused diet, calorie restriction, or ad libitum without a self calorie target may be used to prescribe diet with a varying macronutrient composition. The most common macronutrient manipulation are low fat, low carbohydrate, and high protein. How about the diet pattern? I mean that focusing on a specific food and food type, for example, like Mediterranean diet uses a high consumption of vegetable, fruit, legume, and grain, and moderate consumption of dairy products, and a relatively low intake of meat and meat products. The other thing I think that's very important is about the behavioral therapy as a supportive measure. Cognitive behavioral therapy for obesity is a novel approach that is intended to assist patients in maintaining long-term weight loss by personalizing the intervention and emphasizing the development of behavioral change, like eating or exercise habits. The goal of cognitive behavioral therapy are to help patients to achieve emergence and sustain the healthy level of weight loss, adopt and sustain a weight controlling lifestyle, create a consistent weight control mindset. 76% of patients who finish the cognitive behavioral therapy for obesity show an average weight loss about 9.9% after 18 months and 11% after 6 months. A substantial decrease in cardiovascular risk factor, anxiety, depression, and eating disorder psychopathology, as well as an increase in obesity-related quality of life were linked to this weight loss. Thus, a psychological approach is crucial in managing cardiovascular risk, particularly in relation to overweight and obesity. And then the combination of calorie restriction and maintaining appropriate level of aerobic physical activity or exercise training is the best method for encouraging weight reduction. Weight reduction program combining exercise and food restriction have been proven to result in higher weight loss than programs solely improving exercise. 80% of individuals are unable to sustain weight loss. The high rate of unsuccessful weight loss has been linked to the regression in significant cardiovascular risk factors. Of course, that we need a long-term combined specific intervention for weight loss maintenance program, and then weight maintenance and long-term outcomes are substantially enhanced by ongoing interaction with the healthcare providers or in group context. What is the challenges and limitation of lifestyle intervention? First, patient factors, including lack of recognition of obesity as a chronic or relapsing disease, misbelief and misinformation about obesity management and environment factor, cause and patient comorbidities. And then secondly, about the frequency of patient contact, individualizing patient care and face-to-face intervention. Patients who attend group session may prevent weight regain because it's very important to maintain the weight. And then the third is about the physiological, psychiatric, and medical comorbidities. Patients with obesity often have physiological issues that can negatively impact long-term adherence to behavioral intervention. For the long-term adherence, the target is to achieve weight reduction, maintain weight loss, and prevent weight gain Patients must be motivated and committed to behavioral therapy, which are essential for lifetime weight control. What is the future direction about the obesity treatment? First, about the mHealth intervention, digital or telemedicine monitoring, because it is very important to design to empower patients to change and sustain healthy behavior and weight management. I think that patients not always come to the hospital or to the clinic. And then secondly, about the new therapeutic intervention, I think that the next speaker will talk about this, about semaglutide, liraglutide, and tirzapatide, a new license combination with GLP-1 GIP receptor agonist. This is an example of a glucagon-like peptide-1 receptor that have shown promise in treating obesity and cause notable weight reduction. Of course, for the next speaker, we'll talk about the bariatric surgery. This procedure is highly invasive. Bariatric surgery is known to be a very successful treatment for obesity, facilitating weight reduction, lowering mortality and comorbidity associated with obesity, and improving quality of life. As take-home messages, lifestyle interventions, combined diet, exercise, and behavioral support are essential for improving weight loss, cardiometabolic health, and functional capacity in overweight and obese individuals. Adherence is crucial, requiring regular support, motivation, and strategies to address barriers like time, cost, and physiological factors. Personalization is the key. Tailoring intervention to individual needs ensure better engagement, long-term success, and improve outcome for diverse patient population. I think that's all. Thank you very much.
Thank you, Dr. Amari, for the excellent talk. Actually, I learned quite a lot from your talk. May I ask you one question? Because you mentioned self-awareness is very important. Actually, self-conscious and regular monitoring is also very important. Now, in the era of AI, how do you think if AI can help in this regard?
Yeah, I'm sure that the problem is patients with obesity sometimes come to you with the depressions, with mental health problems, and then they have a problem to going for the doctors for the help. With the EI, I think it's help for you. For example, that you can choose EI for the monitor the patients and give advices, even though it's not the patient not always should come to the hospital. I think in the future, telemedicine AI will have, especially with the wearable device, for example, that you can give an exercise prescription for the patients, and then to monitor the heart rate, etc., etc.
Good. And we have one question from the audience. You have mentioned interruption of food, and how about ketogenic diet? And is it efficacy and its safety? How do you think about it? Because so many people now follow this kind of diet.
Of course, yeah. We know about the keto diet. We learned from a lot of study with the keto diet. You can use keto diet in short period, maybe about 6 months, but you should be careful because with the keto diet, it will increase your LDL-C cholesterol and the total cholesterol. Actually, that is very, very dangerous. For long term, for short term, it will be reduce your growth weight. But for the long term, more than 6 months, I think it is harmful for the patient, especially for the ISCPD patient.
Okay, thank you so much. Because of time constraint, I think we need to go to the next talk. Thank you very much,
thank you very
Dr.
much.
Amari. Thank you. And our next talk is given by Dr. Pauline Lin from Taiwan. Pauline Lin is now working in McCain Memorial Hospital, Hsinchu Branch Hospital. He is currently assistant professor in Nursing and Management Department of McCain Junior College of Medicine, located in New Taipei City. Pauline Lin is an experienced cardiologist. His major in intervention cardiology, including cardiac implantable electronic device and cardiovascular medicine in all aspects. Now he will give us a talk regarding semaglutide, the first GLP-1 receptor agonist proved to improve cardiovascular outcome in obesity and obesity-related HFpEF, seen through SELECT, STEP HFpEF, STEP HFpEF DM. Now let's welcome Pauline. Pauline, please.
Okay. So thanks, Professor, for introducing me. So, Professor, can you see my slide?
Clearly, thank you.
Okay. So it's my honor. I'm Dr. Lin, come from Taiwan. It's my honor to have the opportunity to talk about the SELECT and the STEP-HFpEF and the STEP-HFpEF diabetes. And today, at the first slide, we need to know obesity is an important risk factor for heart failure. So compared to when patients have a higher BMI, you can see the red line. The red line is heart failure. The incidence of heart failure is higher than CHD and stroke. So today we want a patient to lose our body weight, but we need to know why is the major outcome will be improved after body weight change. So today is my talk. I needed to talk about a CV outcome in weight management. The first one I needed to talk primary prevention, and the second one we'll talk about the secondary prevention. The first one we'll talk about primary prevention. We needed to know step. We know that stepping into the obesity-related heart failure. If a patient have obesity, but he did not have any lipid level or hypertension or diabetes, but they will increase the risk of heart failure about 96%. This is higher than cerebral vascular disease and coronary heart disease. So when patients have a higher BMI, you will experience higher risk of heart failure. So in the past, we know the mechanism of GLP-1. The treatment can modify the risk of severe outcome. It includes the direct effect, include about the vascular inflammation, and the indirect effect include body weight reduction and the A1C reduction and the blood pressure reduction. So according to the previous GLP-1 research in the diabetes, you can see when we use the GLP-1 to treat diabetes patients, you can reduce the MACE, including the hospital admission for heart failure. So today in the primary we use in the primary prevention for heart failure. So the STEP-HFpEF and the STEP-HFpEF diabetes is designed for the primary prevention for heart failure development. So you can see that including criteria, patient have a BMI more than 30 and the LVEF more than 35%. It means include mild reduced EF and HFpEF patient. I say that compared to the right side, the HFrEF, HFpEF is have more correlation with the BMI increasing. Why? Because the HFpEF have more correlation with comorbidity because it may have higher prevalence of hypertension, obesity, or the coronary micro or macro disease and the diabetes. So we can look at the detail of the STEP HFpEF. You can see this one is female predominant. And the mean age about 17 years old, and his mean BMI is around 30 or 37. So from the program heart failure, we can in the program heart failure we see the female have a more efficacy to use the ANI in treating HFpEF. In highlight the sex issue in treating HFpEF. So we can have when women meet the menopause, you maybe have some hormone deficiency, especially estrogen deficiency. It will result in myocardial structure dysfunction or vascular dysfunction, and then the estrogen deficiency will induce the HFpEF increase the risk. The second, we can see the STEP-HFpEF, the comorbidity. The first one is hypertension. The second one is atrial fibrillation. So patients have the hypertension and obesity combined with the CKD and atrial fibrillation. They will result and the HFpEF will increase the risk of HFpEF. So in the last year, ESC guidelines suggest if we meet the HFpEF, maybe we can use diuretics or SGLT2 inhibitor to treat HFpEF. But I need to ask one question. When patients have the obesity-related HFpEF, the SGLT2 inhibitor is still useful? So we can look at the Emperor Preserve. I think the empagliflozin is useful. It's better in the BMI less than 30. And then we can look another study about the delivery is dapagliflozin. The dapagliflozin is better than placebo across the BMI index. I think that the two HFpEF have two different outcomes. According to Taiwan's heart failure guideline, it suggests the anti-heart failure medication is according to previous, including LVEF criteria. So I think that the GLP-1 have a role in treating HFpEF. This is why we gather together and talk about the GLP-1 receptor agonist in treating HFpEF. So after the STEP HFpEF is published, I think it highlights the importance of the obesity phenotype of HFpEF. Because obesity will induce the increase in leptin and reduce the BNP level, and will increase the RAS system, and then they will increase the plasma volume, increase inflammation burden. They will induce LV, stiffness, and feeling pressure higher. So will induce clinical HFpEF. And at the same time, the edible tissue will make the compliance of the chest wall as reduction, and they will induce worsening the symptom of heart failure. So we can see the result, HFpEF and the HFpEF-DM. During the trial, we can see the significant body weight change after the semaglutide use, but the body weight change is most significant in patients without diabetes. It's the same in the KCCQ. It's the STEP HFpEF and STEP HFpEF-DM. Also, it can improve the KCCQ, but the KCCQ is improvement is better in the patient without diabetes. And the subgroup analysis, we can see when patients have greater body weight reduction, they will get better KCCQ improvement. So compared to the previous HFpEF inhibitor include number preserve and the deliver, if we want to focus on the KCCQ improvement, I think STEP HFpEF, especially the semaglutide, have a better and the most significant KCCQ improvement compared to the previous SGLT2 inhibitor trials. And then another we will talk about the atrial fibrillation. As we know, HFpEF patients have a lot of about the correlation with atrial fibrillation. So the STEP HFpEF popular another subgroup analysis about atrial fibrillation. I think we see patients with obesity-related HFpEF and F, they are always older and always male and more advanced heart failure and greater the use of diuretics. So if we want to focus on the body weight change, patient with F or without F, they have the same effect on the body weight change. However, we want to focus on the KCCQ improvement, or it's different. If a patient have the patient have the HFpEF and the atrial fibrillation, they will have greater improvement of KCCQ than patient without F. Wow. And then another different, if you want to improve the KCCQ, you want to improve 5, 10, 15, and 20 points, you can see a patient with HFpEF and atrial fibrillation, they will get better KCCQ improvement with atrial fibrillation after the semaglutide use. So we compare to the different patient with F or without F, they have the same effect on the CRP reduction and the NT-proBNP reduction. So we want to know why patient use semaglutide can improve more KCCQ in patient with F. So I think the most mechanism we need to know the mechanism of obesity immediate atrial fibrillation. Especially we need to focus on the hemodynamic and the structure change, especially at the epicardial edible tissues effect. So we can see another subgroup analysis of STEP HFpEF. You mentioned you want to talk about the cardiac structure and the function in obesity-related HFpEF. You can see more than 80% of STEP HFpEF patients have enlarged left atrium. You can see after you after you use semaglutide body reduction, but we can see we don't have any influence on LVEF. But after the body weight reduction and maybe the edible tissue is reduced, you can see the patient's diastolic dysfunction is improving, and at the same time, LA volume is increased smaller than placebo group. But after we correlation with the body weight, I think the patient when larger body weight reduction, you have a larger LA volume reduction. And the second, after the LVA and the LV improvement, and then you can see the pulmonary pressure is also improving. You can see the right RV systolic pressure is improving after the semaglutide use. So in this figure, we can see when we use LV, or we use we can talk about the temporal disease progression HFpEF. The first one we need to talk about the LV dysfunction. LV dysfunction then will induce RV dysfunction. But according to the state HFpEF subgroup analysis, it can, after you use the semaglutide, it can improve LV function, dietary function, and can improve LV remodeling. Then you're improving RV systolic pressure. So after you control the remodeling of your heart, and you can see the patient will get better, and you have better KCCQ improvement. So this body weight issue is also announced in this year's ESC guideline for atrial fibrillation. It suggests if a patient want to prevent, we need to control body weight. If you want to improve, reduce symptom or reduce a burden, you need to target more than 10% body weight reduction. So after the STEP HFpEF is published, we need to know the obesity phenotype of HFpEF is very important, and especially we needed to focus on the issue of a visceral and pericardial and the intramuscular fat, and then it will induce some heart failure. So this is our Taiwan's guideline for the HFpEF. So HFpEF is very important, diabetes is important, but we need to know but where the reduction for obesity is also important for HFpEF. Okay, the second we will discussion on another one is secondary prevention. When patients have ASCA, is it safe to use semaglutide to body weight reduction? So we say selecting ASCA outcome beyond body weight loss. So this is the inclusion criteria and the exclusion criteria of SELECT. In SELECT, you need to age more than 25 years old, BMI more than 27, and with established CV disease, and they exclude diabetes patient. If your patient A1C is more than 6.5, is excluded from this study. So during the SELECT trial, you can see that you have more than about 10% body weight reduction during the SELECT trials. And then we can see the first one, after the body weight reduction, you can see in the ASCA patient, it can have the 3-point mass reduction about 20%. It includes CV days, non-fatal MI, and the non-fatal stroke. And the second, we want to focus on heart failure. You can also another 18% risk reduction, including CV days, heart failure hospitalization, and the urgent medical visit for heart failure. So after the body weight change, we know it can induce some diabetes remission and reduce our blood pressure and lower the risk of the kidney adverse outcome, including persistent more than 50 reduction in HFR and the new onset of persistent macroalbuminuria. So today, another issue is very hard is about the cardiovascular syndrome. So BMI have some correlation with cardiovascular syndrome. When in this trial, you can see when patients have higher BMI, they will have higher risk for cardiovascular syndrome. So in the past, in our cardiology, I want to know if we can control body weight, maybe it can improve hypertension, diabetes, lipid, or diabetes. But today, after the HFpEF, the trial is published, we know if the patient have a high ASCA burden, and we want to change lose the patient's body weight, it can induce better heart failure outcome, better HFpEF outcome, and better CKD outcome. But finally, we want to know, we know GLP-1 can modify risk of CV outcome, but the true mechanism in the SELECT trial is related to muscular inflammation or direct to weight reduction. So in the previous leaders study, you can see here, in the previous, we know the body weight reduction is only contribute to only about 16% of CV outcome reduction. And then we combine from the leader and the statistics, these liraglutide and the semaglutide. You can see we need to target improvement, they will improve our CV count. It includes body weight loss and the reduction in the A1C and the blood pressure and the LDL. And we have no influence on HFR, or even we need to improve our UACR. So if the multi-target is improving, I think the patient will get better CV outcome. However, the select will impact our CCS guideline. So it suggests the GLP-1 receptor agonist, especially semaglutide, should be considered in CCS patient without diabetes, but with overweight or obesity when BMI is over 27, and we can use semaglutide to reduce CV mortality, myocardial infarction, and stroke. Today, this is a 2A indication. So you can see the body weight influence and then the contribute to the CV outcome. We can see only 20%. So you needed to know another 80% is related to other issue improvement. So especially on weight circumference and the HSCRP and the inflammation burden and the HbA1c reduction. So it is not only body weight reduction, is when we use the semaglutide to control obese patient with ASCA, it can improve another parameter, and the those parameter can improve our CV outcome. So we don't want to know the precision medicine in secondary prevention. So another important issue is inflammation. In the previous, we may use colchicine or the interleukin 6 or what interleukin 1 beta medication. But the study is still ongoing. But we know obesity will induce the higher inflammation burden. Okay, induce higher CRP and interleukin 6. So in the select trial, we can see after we use the semaglutide, we can see a consistent reduction of HSCRP. And when higher CRP will be a higher risk of CVOT, but if you have lower CRP, maybe patient will have lower CV outcome. So today we want to improve our precision medicine in secondary prevention. That we can focus on a lipid label, we can focus on inflammation burden, we can focus on metabolic disease like HOT or GLP-1, we can focus on antiplatelet or anticoagulation, but I think we need to pay more attention about obesity. So this is my last slide, and thank you for your attention.
Thank you, Dr. Lin, for the excellent talk regarding the pharmaceutical intervention with GLP-1 agonist. So I would like to ask you a question. As you mentioned, for the GLP-1, the effectiveness seems excellent, especially in obesity patient with atrial fibrillation. And you have mentioned that the atrial remodeling is one of the key mechanisms. So in the patient treated with GLP-1 agonist, is there any evidence to show that the atrial fibrillation will convert to sinus rhythm, or if it's better if we try to use other ways to convert the atrial fibrillation back to sinus rhythm? How about this? Thank you.
Thanks, Professor. Yes, question. It is a very important issue because in our previous data, we can see when patient want to control body weight more than 5 to 10%, and they will keep the size will be maintained. And another issue is when patient experience atrial fibrillation operation or quiet operation, after the quiet rhythm control, if you pay patient with another not 10% body weight reduction, you can even higher chance to maintain sinus rhythm. So according to before operation and after operation, I think the body weight issue is important for prevent atrial fibrillation.
Thank you. And any question from our panelist or our co-chair?
Thank you very much, Professor. You see that a GLP-1 receptor agonist actually nowadays used for the patients in obesity without diabetes mellitus. How about the blood glucose reduction in patients without diabetes? It's safe enough in patients with obesity without diabetes using a GLP-1 receptor agonist? Hello?
Hi. Pauline, do you hear? Okay.
I'm here. See. According to the I think that in the past we know the GLP-1 maybe induce the increase the rate of heart and then science rate, but it did after the severe outcome from the select and the HFpEF, we did not find the instant rate of atrial fibrillation will be higher if using the GLP-1, but I think the mechanism of obesity induced F is complex, but maybe in the HFpEF subcutaneous about atrial fibrillation, that they still did not know the true mechanism why we use semaglutide can reduce the KCCQ, it can improve the KCCQ symptom especially in atrial fibrillation. But they suggest maybe the possible cause, one mechanism is related to LA remodeling, especially environment burden over LA epicardial edible tissue reduction.
Okay, thanks for the reply. Because of the time constraint, I think we need to move next. May I just pass the chair to our co-chair, Dr. Ambari. Dr. Ambari, please.
Thank you very much, Professor Ye. Okay, we proceed for the next speaker. Our next speakers will be Dr. Pakapon Sri from Thailand. He is a general surgeon and then work in a minimal invasive surgery unit, Department of Surgery, Rajviti Hospital, Bangkok, Thailand. And then he will talk about the bariatric surgery to improve cardiovascular outcomes in morbid obesity, observational evidence of long-term efficacy after sleeve gastrectomy or Roux-en-Y surgery. Please, Dr. Pakapon, time is yours.
Okay, so good afternoon, everyone. My name is I'm Dr. Pakapon from Rajviti Hospital, Thailand. So I'm sorry about my cam is not work for today, but I will do my best because I'm only one surgeon in this meeting. That's right. Okay. I will share my slide. Do you see my slide now?
Okay, that's clear. Maybe you should put it in a slideshow.
Yeah.
Okay. Excellent. Please, Dr. Pakapon.
Okay. Okay, I have no disclosure at all today. Today outline my talk is about the obesity and cardiovascular disease consequence of it. But Dr. Chow talked a lot about the how obesity happen to the cardiovascular symptoms. But today I will talk about the bariatric surgery in 4 questions. The first is why we have to perform the bariatric surgery, and the second is what is the mechanism of the bariatric surgery, and when is the indication for surgery, when we have to send the patient to the surgeon for to make the surgery, and how bariatric surgery can improve the CV outcome. So introduction, Dr. Shah talked a lot that we have a problem for now with the obese patients. In 2017, we have 4 million deaths from the overweight and obese, and the prevalence of the obese is go up in 1 year from 30 to 42% in 1999 and 2000s, and the obesity can make the lifetime obesity short about 7 to 10 years. It depends on the how severity of obesity you are. The mechanism, what happened to obesity to the cardiovascular, they can happen to many systems of our body, actually by the inflammation methods to the cardiovascular disease and the diabetic and blah blah blah, many more that we talked before. So the first one is about the bariatric surgery and why. And the previous cardiologists talk about this look head trial. I will emphasize again that this is a key paper in 2013 that talk about what effect about the cardiovascular effect of the intensive lifestyle intervention in type 2 diabetes. These RCTs can summarize for us that we can lose weight about 7% to improve your weight loss, to improve your physiologies and health. But actually, the intensive lifestyle intervention focusing on weight loss did not reduce the rate of cardiovascular event in overweight or obese adults with type 2 diabetes. So from this paper, we can know that weight loss can help people with obese to improve the diabetes, lipid, hypertension, and many diseases. But for that time, I think only the intensive lifestyle maybe cannot decrease the weight loss to improve the cardiovascular event at that time. So in 2017, we have the big RCT from semaglutide in USA. It includes RCT from the 3 arms. The first arm is the sleep gastrectomy. The second arm is the Roux-en-Y gastric bypass. And the third arm is the medical control. We have 150 patients. So the conclusion from this primary outcome, we look for the hemoglobin A1C, glycated hemoglobin on DM, and how to improve about the DM after the operation. So we can summarize as a medical treatment with Roux-en-Y, with medical therapy with Roux-en-Y gastric bypass and sleep gastrectomy shown to be superior to the medical therapy alone in the long-term treatment of type 2 diabetes. Actually, in this group is the patient obese with the DM. So from this paper, we can know that the bariatric surgery become good and have a cardiovascular effect benefit for our patients. So what is the bariatric surgery? Today I will touch not too deep for you about how bariatric surgery can make the people good in many physiology. The first, the caloric restriction. As we know that bariatric surgery, we didn't cut the fat on your belly, on your arm or your leg, but we decrease the size of the stomach and reroute the gastrointestinal route. What can make it happen? So I will discuss later about the procedure for briefly, but the total mechanism, the first one is the caloric restrictions can produce the weight loss for these patients. And the second one is the hormonal change. We can change some neurohormonal of our body after the surgery. We can increase the GLP-1 to make the insulin resistance better and decrease the ghrelin, which is the hormone for hunger. So if we cut the stomach, so we reduce the ghrelin, so the patient can eat, can feel full all the time, and they're not hunger too much. The third one is the improved insulin sensitivity for us to improve the DM. And the third one, the fourth one is the reduction of the inflammation. That we know that inflammation process can make the worse for overall of our body, such as the NASH and DM and OSA and cardiovascular event. And look at the left picture, we can see that if we have if the individual have the obese or overweight, they can have a lot of disease, OSA, depression, disease of the head to toe, and the bariatric surgery can help this patient to improve quality of life and decrease the mortality later. So for now, days about the procedure of the bariatric surgery. So we can categorize 3 types of the bariatric surgery. In the first one is the restrictive procedure. The procedure that we want to reduce the chamber of the stomach or the small bowel to let the patient can eat to small portions. And the second one is the more absorptive one. Is is the lowest. We can reroute the gastrointestinal tract to make the neurohormonal change and the nutritional absorption decrease. And the third one is the combination of both techniques. So for now, what we have now for now? The first one, restrictions. We all know about the first one is LSG or sleeve gastrectomy. This picture, we have to cut the stomach out, about 80% of the stomach out to leave out only 10 to 20% of the stomach. This method can make the patient can eat 2 small portions. And actually for this portion of the stomach is a fundus body, is have the parietal cell that can produce the ghrelin hormone that make the patient hunger. If we cut it, so the patient will feel not hunger, feel fullness by the time as they can eat too difficult. And the other one is the ESG, is called the endosleeve. We suture the stomach to the small portions by endoscopy. It's not the surgery for the laparoscopy, it's only the endoscopy. This is a new method one. And early, about 30 or 40 years ago, there's a adjustable band or AGB. We put the machine to reduce the proximal body and fundus of the stomach. This is only the restriction procedure. And this one is VBG, vertical band gastroplasty. These two is the we not do for nowadays. For now, is for the restriction procedure is only the sleeve and ESG. And the more subtle one we not do anymore is about jejunal ileal bypass. We bypass a proximal of the jejunum to distal ileum. They have a problem with the nutritional deficiency too much, so we not do for now. So for now, they have only the restriction and the combination. Combination is the most potent one is the Roux-en-Y gastric bypass, and the other is the BPD or AGB or mini gastric bypass or sleep plus procedure. That's the procedure that do a lot in the Asia patients. And I will talk later about why we have to do it. Okay, for my talk today is about the gastric bypass and sleeve. This is the most famous for now operation that we can see in the paper or the literature in the 30 years times. The first one is the sleeve gastrectomy in the right side. We cut that I told you before. We cut the stomach out at the greater curve, and you see there's a big stomach that we put it out. So this is the restrictive one. That's the patient will become more not too much hunger and eat too small. And the second one is the gastric bypass. We cut the stomach into just the side of the big the small orange, and bypass, reroute it to the distal jejunum, and we make the reroute again through the bililopancreatic limb to the jejunal rim over here. So that's make the first one is to do the small portion of feeding, and the second one reroute the neurohormonal and reroute the absorption. They can absorb the food too small. So what happens to this operation? They have effect for all the gastrointestinal hormone and the absorption, include and induce the GLP-1 peptide YY to make the insulin resistance better. So about the transorbaric surgery today, as we know for now, that sleeve gastrectomy is the most common procedure because it's too easy to do, because it's just only the cut of the stomach and not make any anastomosis of the bowel. And the second one is the gastric bypass. but adjustable band or the BBDS or the vertical band may be not used for now. So, and above the age, and for now, there is some sleeve gastrectomy with plus some bypass procedure, just as a proximal jejunal bypass. We cut the sleeve and then make reroute of the absorption way. And the third one is the CDS that we can see that they approved by the ASMBS of the USA to one of the bariatric surgery for today. And when we do the bariatric surgery, we know from the WHO classification that the BMI that overweight is more than 25 and the obese is 30. An indication for 30 years ago, the NIH or National Institute of Health in 1991, they categorize the indication for surgery as if the patient have BMI more than 40 kilogram per meter square with or without comorbidity, or the BMI more than 35 kilogram with comorbidity, we can let the patient to make the bariatric surgery. But for the Asian people, we have the prevalence of the diabetics and cardiovascular disease is higher, even the low BMI. So we decrease the indication for surgery about 27.5 kilogram per meter square for the operation of the obesity. And the latest guideline, after we use for 1991 guideline from NIH for 30 years, we have changed the indication for bariatric surgery for all over the world. That's if the patient have more than 35 kilogram with or without comorbidity, they can be select for the operation of the bariatric surgery. And how bariatric surgery can make the good. We have a paper. This is from JAMA paper. But it's only the retrospective cohort study. Include about 15,000 patients with a batch 1 to 5 control. And the primary outcome is the occurrence of the coronary artery event, cerebral vascular event, heart failure, atrial fibrillation, nephropathy, and all-cause morbidity. For this paper, we can conclude that the metabolic surgery significantly associated with lower risk of the major adverse cardiac event with a hazard ratio of 0.6. And in the subgroup analysis show that metabolic surgery associated with 40% reduction in severe morbidity. And they decreased about 40% in death, 30% in heart disease, 60% in heart failure, 30% in stroke, 60% in kidney failure. By surgery on 13 people, one life can be saved. And in the recent 5 years, we have many of the paper do about the bariatric surgery compare with the medical therapy or the non-surgical group. Many include the gastric bypass and include sleeve gastrectomy, include both of them. Some include only one gastric bypass. Every paper seems to be in the same way that they improve the DM, hypertension, cardiovascular accident, CAD, and decrease the risk of the mortality from the bariatric surgery. And the
time, Dr. Bhargava?
Yeah. Okay, yes, they are nearly finished. And so the one is the meta-analysis that show the same way that bariatric surgery can beneficial effect on the CVD outcome. So my conclusion today is bariatric surgery, particularly in the sleeve gastrectomy and Roux-en-Y gastric bypass, can provide a long-term cardiovascular benefits. And significant improvement in blood pressure, cholesterol, and insulin resistance contribute to reduce cardiovascular morbidity and mortality. And surgery is considered is the option of the patient for morbid obesity to decrease the cardiovascular event. Thank you.
Thank you very much, Dr. Pakapong. I think that I learned a lot about the bariatric surgery, especially cardiologist. And then thank you very much for the new knowledge. And then I think that's I will have two questions. First of all, what is the common side effect actually from the bariatric surgery? And secondly, maybe you can answer how to choose which type of bariatric surgery for a specific patient. Thank you.
But for the first question again.
What is a common side effect? The common side effect from your experience with the bariatric surgery.
Okay. First, the side effect or the adverse effect of the bariatric surgery, because we have to first we have to know that if we do the sleeve or we do the which option that we do for the patient, because the sleeve we have a problem with GERD too much for the patients, but for the bypass, any gastric bypass or the other bypass, the patient will have a problem with the nutritional deficiency. But actually we have to make the long-term follow-up to see they have a problem with the vitamin deficiency or with the deficiency or the other or protein deficiency. And for the second one.
And then how to choose which type of bariatric surgery for a specific person?
Yes, for my there's many of the operation. From the literature, if the patient have the more than 50 kilogram per meter of BMI, so we decide to do something more than the sleeve gastrectomy, such as a bypass or the sleeve plus in this procedure. But we have to know that this patient have no contraindication for that operation, because some operation we cannot do bypass, some patient we cannot do only sleeve. So we have to emphasize on the truly indication or the contraindication of that option for the patient.
Thank you very much, Dr. Pakapong. Due to the time, I think that we should move to next speaker. I think you can stop sharing the screen. Okay. Thank you very much. For our next speaker, it will be Dr. Erito Dakato from Japan. She is from a cardiology department, Kyoto University Hospital, Kyoto, Japan. And then she will talk about the GLP-1 and GYP dual receptor agonist, tirzapatide, on the horizon to improve cardiovascular outcome in obesity with or without comorbidities, seen through SURMOUNT-1-3 possible SURMOUNT MMO. Please, Dr. Kato, time is yours.
Yes, thank you, Dr. Ambari, for your kind introduction. And I'd like to take this opportunity to thank the APSC and also JTS for inviting me to this important meeting. I'm trying to share my slide. Just a moment. Can you see the full screen?
Okay, we see the full screen.
Okay, great, thank you. Okay, so here is my COI. So as you heard from the previous speakers, obesity and heart failure are closely linked, with obesity being a major risk factor for the development of heart failure. In the interest of time, not going into details, but I like to stress the pathway from obesity to heart failure involves several mechanisms, including metabolic, inflammatory, and hemodynamic changes that ultimately lead to cardiac dysfunction and remodeling. The history of anti-obesity drug development has been challenging. There has been numerous attempts with various mechanisms, from thyroid hormone to appetite suppressants. However, many promising agents were withdrawn due to safety concerns. So tirzapatide marked a historic breakthrough in obesity treatment as the first-in-class dual agonist targeting both GIP and GLP-1 receptors. Its novel mechanism mimics the body's natural incretin response to meals, but with sustained therapeutic effects. The drug's 5-day half-life enables once-weekly subcutaneous administration, optimizing convenience and potentially improving treatment. So the dual mechanism produces complementary metabolic benefits. The GLP-1 components drives appetite suppression and reduced food intake while enhancing insulin secretion and decreasing glucagon release. It also promotes cardiovascular health through direct protective effects, though this comes with a modest increase in heart rate. So additionally, it slows gastric emptying and stimulates lipolysis in adipose tissue, though nausea can occur as a side effect. And GIP activity adds several unique advantages. So while reinforcing appetite control, it does so without intensifying the nausea often associated with GLP-1 therapy alone. And although it shares GLP-1's insulin-stimulating effect, GIP distinctly increases glucagon and modulates fat metabolism by enhancing lipid deposition and lipogenesis. So, but perhaps most notably, GIP offers the added benefit of reducing bone metabolism. So tirzapatide is being extensively evaluated through a comprehensive clinical development program, as you can see here, encompassing multiple ongoing pivotal trials. And the research framework consists of three distinct focuses. One is the SURMOUNT series, investigating its effect on obesity management across diverse population targeted, and then those trials targeting obesity-related complication, including heart failure, sleep apnea, liver disease, and kidney disease. And then there's a landmark outcome trial, SURMOUNT-MMO, assessing long-term morbidity and mortality. So these trials aims to establish tirzapatide's efficacy not only in weight reduction, but in also addressing the broader spectrum of obesity-related diseases. So today I'll share the clinical evidence from the SURMOUNT trial program. It's a landmark series of phase 3 studies evaluating tirzapatide for chronic weight management. So this comprehensive program includes SURMOUNT 1, 2, 3, 4, and SURMOUNT 1 has investigated tirzapatide in adults with obesity without type 2 diabetes, and SURMOUNT 2 focusing on participants with both obesity and type 2 diabetes, whereas in SURMOUNT 3 examined weight management following an intensive lifestyle modification program, and SURMOUNT 4 assessing sustained weight loss maintenance. So these trials collectively provide robust evidence for tirzapatide's efficacy across diverse patient characteristics. So the SURMOUNT trials enrolled predominantly younger adults, as you can see here, with mean ages ranging from 45 to 54 years across studies, which is much younger than compared to other studies. And the study population was largely white, with Asian participants unfortunately representing approximately 10% in most trials. And a clear female predominance was observed in most trials, and the vast majority of participants had BMI greater than 30, with approximately 1/3 having BMI of greater than 40, highlighting the focus on treating individuals with severe, moderate to severe obesity. So in SURMOUNT 1, tirzapatide demonstrated dose-dependent weight loss across 5 milligram, 10 milligram, and 50 milligram doses versus placebo. The 50 milligram dose achieved the mean weight reduction of 20.9%, which is stunning from the baseline, and compared to 3.1% with a placebo. and weight loss occurred rapidly in the first 24 weeks, and continued through week 60 with results maintained until study end at week 72. And even the lowest 5 milligram dose achieved clinical meaning weight loss of about 15%. And on tirzapatide 15 milligram, over 90% of participants achieved more than 5% of weight loss, and over 70% had achieved more than 15%, and more than half, as you can see here, achieved greater than 20% weight reduction. And common adverse events were gastrointestinal, as I have alluded to, primarily nausea, diarrhea, and constipation, consistent with GLP-1 receptor agonist class. And in SURMOUNT-2, examining patients with obesity and type 2 diabetes, tirzapatide achieved a mean weight reduction of 14.7% with 15 milligram of tirzapatide, and 12.8 with 10 milligram versus 3.2 with a placebo. And over 80% of participants on 15 milligram achieved more than greater than 5% weight loss, without about half reaching greater to 15% reduction, demonstrating significant efficacy despite the typically more challenging weight loss in diabetic patients. The weight loss results in SURMOUNT-2, while lower than SURMOUNT-1's non-diabetic population, marked significant breakthrough in treating obesity and type 2 diabetes, because these patients, as I said, it's very difficult to treat. These outcomes substantially exceed the typical 3.3 to 7% weight loss seen with previous intervention, demonstrating unprecedented efficacy in a population that traditionally faces greater challenges with weight loss. So looking at the safety data for level 2 hypoglycemia, there was a dose-dependent but manageable increase in events, and among all patients, the incidence was 1.3%, so which is very low in the placebo group, and rising to 3.5% with tirzapatide 10 milligram, and 4.8% with 15 milligram. So importantly, baseline SU, sulfonylurea use, significantly influence the hypoglycemia risk. In patients on SU, the rates were notably higher, as you can see here. So SURMOUNT-3 addressed the critical real-world question, very interesting. So the question is, can tirzapatide enhance outcomes after lifestyle intervention, as we have seen earlier with a look ahead? So the results are particularly compelling. The tirzapatide group, representing by the blue, demonstrated continued weight loss beyond the intensive lifestyle program, and ultimately achieving a remarkable 21.1% reduction at week 72, And the key clinical insight lies in the diverging trajectory, as you can see here, which emerged early and progressively widened over time, while the placebo group exhibited the familiar pattern of weight regain. As you can see here, we often see this in the clinical practice. But however, with tirzapatide, you can see that there is a progressive weight reduction. So then finally, the SURMOUNT-4 trial tackled the fundamental question in obesity medicine. So what happens after patients achieve their weight loss goals? So the results painted a compelling picture. It's very interesting. So patients who continue tirzapatide maintain their hard-won progress, losing an additional 5.5% of their body weight over 88 weeks. In contrast, those switched to placebo regained approximately half their initial weight loss, highlighting the importance of continuing this medication. So one of the trial that I'd like to highlight, although it wasn't, I wasn't asked to talk about this, is the SUMMIT trial. It's a landmark phase 3 trial that addressed the critical gap in heart failure therapeutics by evaluating tirzapatide efficacy in patients with HFpEF, a condition that, as you know, has long challenged cardiologists with its limited treatment options. So here's the baseline for SUMMIT. Among the trial participants, 19.7% were Asian or resident in Asia, representing an important but relatively small portion of the study population. So we have to be slightly careful about the interpretation of these outcomes. However, this demographic composition were, I think we are going to see the sub-analysis of the Asian population. And for the SUMMIT trial, notably 27 to 28% were classified as New York Heart Association class 3 or 4, indicating significant functional limitation. And the metabolic profile is particularly striking. The patients had a mean BMI of approximately 38, placing them well into class 2 obesity range. And functional capacity was notably impaired, as reflected by the mean 6-minute walk, walking distance of approximately 300 to 305 meters, which is much lower than what we'd expect in healthy adults. The trial enrolled high-risk population. 47% had experienced heart failure hospitalization or required urgent care in the year before enrollment. And the comorbidity burden reflected the classic HFpEF phenotype. Approximately 1/4 of patients had AF, while nearly half had type 2 diabetes, so a very classic population. And while patients received comprehensive guideline-directed medical therapy, SGLT2 inhibitors use was very limited, with only about 17% of the population, reflecting the temporal context of the trial before these agents became a cornerstone of the HFpEF management. Of particular interest was the elevated high-sensitivity CRP level, which you can see here, which is 5.8 milligram per liter. As you, of course, know, the high-sensitivity CRP is a biomarker that tells an important mechanistic story. And this finding aligns with our current understanding of HFpEF as a systemic disorder where chronic inflammation serves as both driver and amplifier of the disease. So here are the main results. Looking at this landmark data over a median follow-up of 104 weeks, tirzapatide achieved a compelling 38% reduction compared to placebo in the composite endpoint of cardiovascular death or worsening heart failure events, with a hazard ratio of 0.62. And the Kaplan-Meier curves tell an interesting story. While they initially tracked together in the first few months, there's a clear separation beginning around week 24, and these divergences become increasingly pronounced as the study progresses. So tirzapatide also demonstrated significant effect on 2 key parameters, weight loss reaching approximately 15% by week 52, and also marked a 40% reduction in high-sensitivity CRP, which again is a biomarker for inflammation, indicating substantial anti-inflammatory effects, while placebo showed minimal changes. Tirzapatide's impact on both measures was progressive and sustained, and potentially explaining its benefit in HFpEF, where obesity and inflammation play crucial pathophysiological roles. So tirzapatide significantly improved functional capacity as well, with a 33-meter increase in 6-minute walk distance versus just 8 meters with placebo. And quality of life also showed meaningful enhancement, with a tirzapatide achieving a 9.5% improvement in KCCQ scores compared to 12.7% points, with placebo, and resulting in a clinically significant 6.9 points between group difference. And the benefit was consistent across virtually all pre-specified populations, you can see here. So tirzapatide's therapeutic benefits, where does this come from? It's mainly, so there's a variety of explanation, but partly it could be explained from the simultaneous effect on multiple body systems. As you can see in the slide, there's a receptor of in the multi-organs. In the liver and muscle, it improves insulin sensitivity and reduces glucose production, and the other mechanisms, as you can see from here. But perhaps the most interesting is inflammation as a key driver in heart failure progression. So when triggered, inflammation initiates a cascade of immune responses that affect multiple organ systems, and this creates a destructive cycle. The initial cardiac stress activates immune cells, leading to chronic inflammation that damages not just the heart, but also the kidney, liver, and the lungs. As these organs become compromised, they in turn worsen cardiac function, accelerating progression from the healthy heart to the heart failure. And then understanding the inflammatory cascade has become crucial in developing and targeting therapies for heart failure, particularly those with obesity. In obese patients, fat tissue becomes more than just an energy storage deposit. It transforms into an active endocrine organ that disrupts immune system function, and the enlarged fat cells produce inflammatory cytokines that recruit and activates various immune cells, including macrophages, T cells, and other inflammatory mediators. So this is very important. And and the connection between inflammation and cardiovascular disease was powerfully demonstrated through CRP research. As you can see, the CRP is highly associated with all-cause mortality, or MACE. And the landmark trial, Kansas trial, provided crucial evidence of this relationship when patients were treated with anti-inflammatory agent canakinumab, which is an anti-inflammatory agent, IL-1 beta inhibitor. Those who achieved CRP levels, lower CRP levels, showed significant reduced rates of heart failure. However, the cardiovascular benefits may not be solely attributed to weight loss, as shown from the previous trials. So this is one of the previous trials that showed weight reduction with anti-obesity drug, but also failed to demonstrate cardiovascular benefit despite achieving significant weight loss. And furthermore, TNF-alpha inhibitors, which are also anti-inflammatory agents, did not show any cardiovascular benefits in clinical studies, and therefore more data are needed in this field. But certainly, inflammation is very important in obesity. And but despite the decades of obesity research, a crucial unmet need remains, as previous speakers has also alluded to, is accurately defining obesity beyond the limitation of BMI. While BMI has served as a convenient screening tool, it fails to capture the complex distribution and metabolic activity of the body fat. And recent evidence suggests that body composition, particularly the distribution of visceral fat around vital organs, may be more clinically relevant. Particular importance is cardiac fat, including both pericardiac and paracardiac deposit, which directly impacts cardiovascular function through local inflammatory pathways. And these ectopic fat deposits serve not merely as passive tissue, but as metabolically active organs that contribute to systemic inflammation and cardiovascular risk, highlighting the need for more sophisticated approach to obesity assessment beyond simple BMI measurement. So that being said, the CMR analysis revealed a significant cardiac remodeling with tirzapatide. The LV mass decreased significantly with tirzapatide, and this was largely due to the reduction in cardiac adipose tissue, which showed a dramatic reduction in both pericardial and also paracardial compartments, while the cardiac function parameters remain stable. So these structural changes, particularly metabolically active cardiac fat, may partly explain tirzapatide's cardiovascular benefits. So here we see the current development landscape of GLP-1 agonists and their combination therapies. At the top, we have GLP-1 agonists in both injectable and oral forms, with semaglutide leading in both categories. And the diagram branches into GLP-1 GIP agonists, amylin agonists, and PYY agonists, showing the diverse therapeutic strategy being explored. And currently, tirzapatide, although this is not a direct comparison, so we have to be careful about the interpretation. However, tirzapatide demonstrates among the most potent effects on both weight reduction and also the glycemic control, achieving a 22.5% weight loss and robust A1C lowering through its dual GLP-1 and GIP receptor agonism. So looking ahead, several questions remain. We need to better understand the impact on body composition beyond simple BMI, and the relationship between adipose tissue distribution and cardiovascular outcomes. So here is the last slide. This is a take-home message. So I have explained that tirzapatide is a novel dual GLP-1 GIP receptor agonist with multifactorial effects, and in which impacts both central appetite regulation and also peripheral metabolism. And it has demonstrated anti-inflammatory effects and potential cardioprotection. And there are accumulating evidences. The SURMOUNT trials showed significant weight reduction of approximately 15 to 22.5%, depending on the dose. The SUMMIT trial demonstrated cardiovascular benefits in HFpEF population. This was just presented at AHA this year, so this is a very timely topic. And consistent benefit was shown across population with or without diabetes. It is very similar with SGLT2 inhibitors. So for the future direction, again, we need to have a long-term cardiovascular outcome data with tirzapatide and investigation on effect on body composition beyond BMI and integration into a comprehensive obesity management strategy. Thank you for your attention.
Thank you very much, Dr. Kato. I think this is a great presentation from you, and then I learned a lot about the tirzapatide. My comment is that if you see from the SURMOUNT 1 and 2, I think that's with a 10 milligram tirzapatide, given optimal benefit, actually almost the same with the 15 milligram. Any comment on that?
Yeah, thank you for that. Very good question. So I think the dosing is very difficult. With the BMI, we have to think about the BMI or body composition, and also we have to think about the body, how much the body weight reduction you see with 10 milligram or 15 gram, and you really have to make personal changes with a individual patient. So, but as you said, but as I've shown in the slides, the risk of hypoglycemia with this agent, GLP-1 receptor agonist or GLP-1 GIP, is quite low. So I would say that if your patient can tolerate 15 milligrams, I would advise to increase to up to 50 milligrams. Although I would say the side effect, which is gastrointestinal side effect, would increase with increasing amount of dosage. So I will be very careful, and also I have to. I think I would recommend to a balance between the efficacy and also safety. Thank you.
Thank you. Last question, maybe, Dr. Kato. Is there any contraindication using tirzapatide or obese patients?
In obese patients?
Yes.
As far as I see from the data, I would say no. But again, the side effect, the percentage of side effects is quite high. It's about 35 to 40%, which is very high when you think about this kind of long-term condition medication. So there are people who cannot tolerate, there are a certain percentage of people who cannot tolerate this drug. And also with there are some problems with constipation that has been reported. So again, with the gastrointestinal, if your patient has gastrointestinal problem, I recommend to talk to the patient about the safety, the possible safety issues.
Thank you very much, Dr. Kato. Is there any comment from you, Professor Ye or Professor Lin, please? Or we should close this session?
Yeah, but my last question. Do you think tirzapatide would be superior to semaglutide in the long run? How do you think? Thank you.
That's a tough question. So currently, there's no head-to-head data comparing semaglutide to tirzapatide, so I have no answer to that. But when you look at the data, the weight reduction, the percentage of weight reduction is much higher with tirzapatide and also with a newer agent. So we have to wait for more data to come out. But if you believe that weight reduction is the main pathway to reducing cardiovascular outcome, then perhaps tirzapatide has a greater benefit. But again, the weight reduction and cardiovascular benefit, we still do not know whether it's we know that it's closely linked, but we do not know if it's absolutely causal or if there is any other pathways or mechanistic that contribute to cardiovascular risk reduction.
Thank you. Thank you.
Yeah, thank you very much. I think there is any comment from the audience or panelists. I think we already at the end for our session this day. And well, I think that we have reached the end of this remarkable webinar about the fighting obesity to improve cardiovascular outcome, novel weight loss therapies on the horizon. I would like to take a moment to reflect on what we have achieved today. Together, we have explored cutting-edge advancement in obesity management and its critical roles in improving cardiovascular outcomes, from understanding obesity as a disease to lifestyle intervention and pharmacotherapies like semaglutide and tirzapatide. Today discussion have been insightful and inspiring, I think. And then I want to extend my heartfelt thanks to all of our distinguished speakers for the time, effort, and expertise. Professor Syed Tahir Shah from Pakistan, Dr. Po Lilin from Taiwan, Dr. Pakapon Tatsri from Thailand, and then Dr. Erito Dakato from Japan. And to my fellow chairperson today, Professor Hung Ye from Taiwan, thank you very much for expertly guiding us through today's session. And then for the program director, of course, Professor Jun Li Lin, thank you very much. And I also want to thank to the IPSC Cloud team and our organization for making this webinar possible. And finally, all of the participants of the IPSC Cloud webinar. And I encourage you to apply what you have learned today to your work advancing cardiovascular health. On behalf of the IPSC, thank you for joining us. We look forward to see you at our future events. Until then, stay safe, stay healthy, and goodbye. Thank you very much.
Thank you. Thank you all. Thank you all.
Thank you very much.
Thank you. Thank you.
Thank you.
Okay. Bye-bye.
Thank you very much. Bye-bye.
Thank you.
Thank you very much. Bye-bye.
Bye-bye.